we might as well get started. So thanks students for attending the seminar. I know some of you are on placement and some of you would be crazy busy doing that last bit of the concept map assignment. Please, if you haven't submitted yet, make sure that you do submit your concept map assignment by 5 p.m. Today. So today we will go through some important announcements before we jump into the actual content. And then today we'll basically be covering an overview of pharmacokinetics, which I believe is the last topic in module 6. Next slide, please. Yep, so here we go. Like I said, concept map due today at 5 p.m. I'm sure most of you have already submitted, but if you haven't, make sure that you do, but do not submit close to 5 p.m. because there'll be much traffic close to 5 p.m. So I'd recommend submitting it a couple hours prior, because if let's say you click submit at like maybe 10 to 5, it's very unlikely that the system will upload your file before 5 p.m. And remember, we've already told you that even a 1 minute late submission will incur a 5-mark penalty. The results, so the marks for your concept map will be released around first week of June. 6th of June, I think, is the 4th week, Matt.
Is it? Oh,
yeah.
There's my there's my calculation for you.
Yep. So give us 3 weeks to mark your concept map assignments. Please be mindful that we've got almost 400 papers to mark. So give us at least 3 weeks.
I think it's more like 600.
It feels like 6. Well,
over
yeah.
Over 3 campuses.
Over 3 campuses. Yeah, that's right. Yeah, it's not 400, it's 600. Yeah, there you go. And the EOT, the end of trimester exam study guide, will be provided to you this Friday. So the EOT exam study guide is basically a very detailed and thorough list of the things that you need to study for the exam. So we've already said this multiple times. You do not need to study every single topic that's in your course site. We will give you the ones that you need to focus on, and we'll go over this study guide next week in next week's seminar. So another reason why not to miss next week's seminar. For those of you who will be out on placement or who are unable to attend, obviously it's going to be recorded. And lastly, online quiz 4, which will assess module 7. It will be due the 3rd of June, Friday the 3rd of June. So please mark this on your calendar. For quiz 3, we've again had more than 50 students across the 3 campuses who had completed their quiz. So this is your last chance to collect 5%. That will contribute towards your final mark, so make sure you complete this. Anything you'd like to add, Matt?
No, there's just a question from Nari here in terms of, can I ask something about the written part of the concept map? So that was, Nari, that was an old version of the assessment guide, which I made a mistake in because, as you're probably aware, previous years, in the concept map, we had treatment and diagnostics, but we have removed those out of the concept map for this year. So within the rubric, it did say that refer to the case scenario, but that's not, sorry, not the case scenario, but the concept map. So that's not the case. So when you're talking about the diagnostics and treatment in your written section, that's the only part that you're referring to with the diagnostics and the treatment is only in the written section. You don't have to talk about that in the concept map at all. Okay. Now, when you do your written section, you do need to justify the written section. So you need to tell us why these particular diagnostics will provide a definitive diagnosis for the patient in the scenario. Okay, and same goes with treatment. You need to outline, using the literature, outline a treatment regime that would be appropriate for managing that particular patient based on their diagnosis. Okay, and so that you should be guided by the literature, and that's the literature will outline quite clearly on regimes that is most appropriate to achieve a diagnosis, but also to manage a patient like this, and therefore you need to write in a way that is, well, that goes on to Florin's question. It has to be 500 words, is 2 pages, double spaced. So that would be more than enough. So 250 words to justify it. You don't have to be verbose, you have to be concise. So it can be done quite easily if you do stick to what the literature guides you, and then all you need to do is make an argument for. So if you're talking about a diagnostic test, what will it do? What will it outline? What will it demonstrate? How will that allow you to move to understanding more about the patient to be confident that there is a diagnosis? In previous years, and we've had this for at least 4 years, we've had 750 words, but that included risk factors, the 5 clinical manifestations, the pathophysiology, the diagnostics, and the treatments. So for 4 to 5 years, students have managed 750 words for all those sections. So 500 words for those 2 should be sufficient. Do you want to add something there, Ewan?
No, no, not at all. I just want to emphasize again that you guys need to be very choosy with your words, very succinct and very concise and straight to the point.
Yeah, and there's already been some assignments submitted, and I'm not going to comment on this, but what I will say is some students in previous years, but I've also seen them in this year, they will go back and start discussing the case scenario again. So that's a lot of words that you're wasting just talking about things that isn't needed to be discussed. Remember, what you're being asked to do here is, if a patient was to present like this, how would the physician go about looking for investigations that would be instructive to be sure that the patient is indeed diagnosed? And we know the diagnosis is a brain or multiple, I'll just say, metastasize into the brain from the breast. So how would you go about to define and be definitive that that is indeed the case? What would you do? And again, you're not the physician here, but you do have the literature, and you need to follow the literature, and you need to use the literature to make your argument. Okay, you're not writing an essay, you're just outlining a process that would provide this evidence. Okay, and you should be able to do each section in one double page, which is 250 words each. Sandra. Concept map, the boxes do not fit in the A4 no matter what I do. Again, Sandra, it really depends on how much you're including. Again, we don't want an exhaustive concept map. We just want to see that you've understand the process. So in terms of the criteria that's in your rubric, there's 3 criterion that you're being asked or being assessed on for your concept map. Okay, so there's criterion 1, which is about the risk factors. There's criterion 2, which is about the pathophysiology, and there's criterion 3, which is about clinical manifestations. Basically, the pathophysiology, which is criterion 2, that is about you demonstrating how does the cause linked to the diagnosis being the brain cancer. So how does the cause link to that? So how does it get from where the tumor originated to where it's now located in the brain? Okay, so you need to demonstrate a process that outlines you understand how it moves from one area of the body to the other. Okay, that's the criterion 2. In terms of criterion 1, which is the risk factors, you need to outline the 3 risk factors, so you need to be able to find them correctly. They're explicitly listed in the scenario. You need to outline how, through their own process, how do they increase the risk of this process occurring? Either the process of the etiology occurring or the process of how does it go from the etiology into the brain. So that's where the risk, because it's increasing the chance of this thing happening. And then the clinical manifestations, how did the 5 signs and symptoms come about? You need to demonstrate that process. Okay, and that's your concept map. We don't want huge amounts of detail. We just want to see that you can understand the process for each. Okay, and you would, so this goes to Sandra's question. In terms of a 1 concept map slide in a PowerPoint, that would be sufficient. You wouldn't need to expand it to an A3. It would just mean you need to refine the number of boxes down in a way and again be succinct. Yun, do you have anything to add to that?
No. Yeah, it's preferable to only use one slide for the concept map, and I think you've explained it quite thoroughly.
Remember, we're not wanting to see that you are molecular biologists. Okay, we want to see that you're nurses. Okay, as a nurse, you will be looking after patients and they will have conditions where they have these symptoms, and you need to be able to understand what's going on in the body for that. We're not fussed by going into huge deep details of genetic mutations and what's happening on the receptors of cells and so forth. Doctors don't even care about that. Maybe pathologists do, but doctors don't, nurses definitely wouldn't. So you're not going to be getting bonus marks by putting in super detail molecular biology. We just want to see that you can piece it together. That's all. And that's the whole function of the concept map. You need to understand it to put it together. If you try to put it together without understanding it, we will see that straight away because it doesn't fit, it doesn't make sense. So I guess my advice is the first thing is to understand it because that will dictate on how you construct your map. Okay, it's better that you have less in it and put it together well than put in a whole lot of detail that you really don't know what it means and try to put it in a way that we can see that you haven't understood. Okay, hopefully that makes sense.
Yeah, just one last tip would be to think about the cases that we've looked at during tutorials. And if you guys remember, there was a similar case to the actual case scenario for your concept map assignment. So think about that as well.
Okay, so let's get into today. You're welcome to keep posting questions, but we'll try and get into some questions for today, or some topic for today. So as Yun said, we're going to now focus on pharmacokinetics. So this is module 6, and this is probably going to be the most important section or topic within module 6 for your final exam. So it's important to know this particular section of the module. So let's start off with a question. Well, this particular one's actually on aging, but it will underpin the changes that we see in pharmacokinetics. So have a quick read of that and then just pop into the chat which one you think is most correct. Good. Okay, so it looks like everyone's put B. So everyone's okay with that as an answer. So in terms of an aging person, and we're specifically looking at the aging adult, which of these four things, well, which one of these out of these four would not be true? And so increased immunity is the case. So you would actually see it decreased over time. C, that's talking in reference to blood vessels. So the blood vessel changes, and we do see degeneration in blood vessels, atherosclerosis. We get stiffening blood vessels. That's part of the reason why they get blood pressure changes, particular widening pulse pressures. Elastic fibers in the lungs, that's in reference to the way that the lungs can rebound back. That's kind of the elasticity, so they have less compliant lungs, and the metabolic definitely does decrease, unfortunately, as we get older. Are there any questions in that on that question, or we can move on? Okay. So next question. So this is now underpinning the pharmacokinetic process. So which out of these four do you think is not part of pharmacokinetics? Okay, good. Now I'm going to go through this now because essentially the pharmacokinetic concept is what we're going to deliver for the rest of today's session. But you were all right by stating that the binding is indeed incorrect. Does anyone know what the fourth one is? So we do have distribution, so that is true. Excretion is true. Absorption. What is the fourth if it's not receptor binding? Okay. Well done, Stacey and Lexi. All right, so let's get into it. So for pharmacokinetics, now, when we talk about pharmacokinetics, you would have covered this in 1807. Is that true? Did you all do this last year in 1807 when you did safe medications? You covered pharmacokinetics and pharmacodynamics to an extent. Yep. So you are familiar with what this process is. Now, okay. Anna, have you done any, so Anna, did you do an EN pathway? Because I'm just thinking, I would have thought, I'd have to check it, but I thought 1807 might have been a prerequisite for 284, that's all. Or maybe it's only AMP. I'd have to check that. Do you know, Ewan, from the top of your head, if 1807 is a prereq? It's own.
Can't remember off the top of my head, sorry.
Okay. All right, I'll have to look into that, Anna, but it would make your job a little bit harder not having done any pharmacology. I think there was a suggested study that have done pharmacology to some extent beforehand. So it may be a slightly more challenging process without doing any pharmacology at all. But anyway, so pharmacokinetics, you can break this term down into two parts. Pharmaco refers to medications or drugs, and kinetics is movement. So really what this is all about is the way that the drugs move through the body. Okay. And it's kind of got four main phases to it. Now, what I'll do is the first two, and Ewan will do the second two. And so what we want you to understand is it's not only what we want you to know is not only how the drug moves in and around the body and then back out, but the effect that age is going to have on this process. Okay, because when you're a nurse, you're the one who's given the medications predominantly. The physicians, the doctors will be doing the prescribing, but you're the one who will be administering the medication. So you need to have an understanding of how this process is going to be affected by age, which is either the real younger person or the aging adult. So that's the kind of context that we're going to look at today. All right, so again, this is just a rehash. I'll do the first two, you'll do the second. So absorption is the way that the drug essentially gets into the body, and more specifically the bloodstream. So that's absorption, how we absorb the drug. Distribution is that how it moves through the body fluids. Metabolism is basically the way that the drug has been modified to get rid of, either to be turned off or to get rid of. And then excretion is how we get rid of it. And that's usually either in the case of, predominantly it's going to be either through the kidneys or through the feces, but there's other ways which Yun will talk to. Okay, so before we get going in absorption, I've just left this slide blank because I just wanted to get you to brainstorm quickly. What are some different ways that drugs may be administered? So this is kind of trying to understand absorption itself. What are the different ways that drugs can be administered in the body? Can you put some examples within the chat? So we've got Sandra, subcutaneous. So what does subcutaneous essentially mean? Where does that go if you were to give a drug subcut? This is going to take too long to write out like this. Subcut, where does it go, guys? Under the skin? Okay. Can you give me an example of a drug that you would give in this particular way? Okay, insulin. And what may be the reason for why you give insulin in that manner opposed to IM or intravenously? Why would you want to give it subcutaneously? Yeah, good, Isabella, that's right. So under the skin, fat, yeah, so it would go into the fat and it would slowly diffuse out of the kind of that fat tissue, slowly into fluid, which then will go into blood, which would then change the release speed of that. Okay, so we've also got oral. I think we all spoke about oral. We've got transdermal. What else have people put above? I'll just go back to it. IM good, IV, PO, intramuscular, under the skin, suppository. Okay, that's good. Topical. What else have I got written down here? You could have sublingually, under the tongue or buccal, cheek, rectally, inhalation, intrathecally, topically. Yep, good. All right, so that's, I just wanted you to get an idea of the different ways that medications can be administered. Now, what would determine how well they absorbed would be a few things. So one of the first things you need to think about is we need to get that particular medication in whatever form that it's in. So it could be as a tablet, it could be as a capsule, it could be as a powder, or it could be as like a fluid. That's going to dictate the way it kind of diffuses or the way it gets into the body fluid. And so this kind of takes us to the transports, the membranes. So when we think about passive transport, do we remember that from A&P? What kind of things influenced the way that something would diffuse either in a fluid or across a membrane? Do we remember? Because this is going to be important for absorption. So Sandra's got size, the form, solubility, the temperature. That's great. Yeah. And also, Anna, that's excellent. Concentration gradient. So, and osmosis, that's more to do with water, Loretta. That may come into it if you're given something that's dissolved in water, but by and large, it's going to determine the concentration gradient, so the way it's moving across the membrane onto the other side. Emma, calcium channels, maybe if it is calcium that you're trying to give. So if it was a vitamin like calcium or a mineral like calcium and you're wanting to give that, then the calcium channels may be of importance. I can't think of calcium channels. I'm potentially wrong, but I can't think how calcium channels in directly themselves will have an influence on the speed of diffusion of particular medications, but I could be wrong there. So yeah, so diffusion across the membranes is going to be very important. A lot of the medications that will be given it's passively diffused, so it doesn't require energy, so therefore it needs to go on its concentration gradient. So when we think of oral medications, like here in this diagram, we can see that we've given these capsules and they have to get put into the mouth, taken down the esophagus into the GIT. So there's going to be a number of things that will influence how quick it can be absorbed across. Does anyone want to have a guess of what certain things in this context of oral medications would influence how well it could be absorbed across into the blood? That's going to come. You're right. You're right, Michelle. Not Kayla, sorry. First pass will come into it, but that's a slightly bit past. It's going to be still part of absorption, but a bit past getting across the gut wall. In terms of dynamics, it's going to be what you had with food. Okay, the pH, the environment, the speed, the transition time. So if you've got a condition that's slowing the speed of things moving through the GIT, that's going to affect the absorption. If stomach acids, that's right, and the solubility of the drug. Yeah. So if it is a fat soluble, it's going to be easier because if you look at the membrane down here, remember this membrane it's a fatty bilayer. So if it's a large molecule or a charged molecule, it's going to bounce off. If it's a small or fatty soluble, it's going to go through. So that makes it easier for diffusion. So when we think about the pH of the environment, okay, what would you expect to see in the stomach? What's the pH like in the stomach? Acidic, right. And so certain acidic drugs that are given in an acidic form will remain what we call unionized, without charge, okay, whilst they're in their same pH. So does anyone know an example of an acidic drug? And this is probably one of the only drugs that is actually absorbed in the stomach. Does anyone know the drug that is one of the only drugs that is absorbed in the stomach because of its pH? It's actually aspirin. Yeah, that's right, Florin. So aspirin, and that's because in its form, it's an acidic drug. So in its form, when it's in the stomach, which is a lower pH, it actually remains uncharged, so it can actually be taken across the membrane relatively easy. Now, when you go down to the gut, but as you go down the intestines, it becomes more basic. So this is where certain basic drugs may be more effective, okay, for absorption. Like, for instance, say some antibiotics. And this is part of the reason, again, why morphine isn't a great drug to give orally, because it has a basic charge to it, and it's kind of ionized in the upper GI, so it's not well absorbed in the upper GI. Okay, so that's why morphine isn't a great drug given orally. Okay, so I guess before I get to the first pass metabolism, the take-home point here with absorption is just its ability to cross membranes and get into the body fluid. So that's essentially what it's trying to achieve. The drug has to first, and it could be all the different forms that you told me in the last slide. What it has to ultimately do is get from the way it's administered into a body fluid. which then hopefully from that body fluid can get into the blood. Okay, and what determines how well it can get into the body fluid is essentially whether it's ionized or unionized or lipid soluble or not. And this would really dictate how well it can cross the membranes, because as you know, we are filled with cells, and what lines our cells are the membranes. So we have to get across that kind of barrier to start with. Now, focusing on the oral route, like you can see here, to get into the blood. So before we can get to the point where we can distribute the blood through the body, we know that the whole gastrointestinal tract, or at least from the esophagus all the way through to the rectum, has to get taken through the liver. And this is what we call the first pass metabolism. Okay, so following this diagram at the top, what it's trying to show you is you take the pill in, it gets digested somewhere across the gastrointestinal tract, and then it has to cross these things, which we call villi and microvilli, which is in the intestines. But before it gets put into the blood, or at least the systemic blood, it has to be taken through the liver, which is the first pass. And so this diagram down here, it's zooming in on it, you can see blood is taken from the gastrointestinal tract via a venous system, which we call the portal vein. Okay, so the entire gastrointestinal tract, 7 meters of it, anything that's absorbed across it, whether it's medications or food or fluid, it has to get taken in the portal system to the liver. Now, why would you want to do that? Why does the body want to have this system in place? Why not just dump it straight into the blood? Close, Sarah. What do you mean by filter it, though? Be a bit more specific. Yeah, detoxify. That's a big one. So you want to basically want to ensure that what you're putting into the blood isn't a harmful poison or a toxin. It is indeed safe. Okay, so the liver, as you know, is made up of hepatocytes, which have a lot of organelles that do this kind of detoxifying role. So if there's anything that potentially is cytotoxic, the liver will kind of get rid of it before it has a chance to get put into the systemic blood. It also has a lot of macrophages and immune cells. So anything that immunologically, like bacteria or viruses or something like that, that you've ingested in your food will be hopefully destroyed or countered before you put it into the systemic circulation. So it's a very important quality control checker before you put it into the blood. Okay, so that's an important thing. But the downside to this is, well, some medications can be destroyed before they ever get a chance to work. And a good example that we put down here is GTN, okay, glycerol trinitrate. Okay, and therefore what that will do is it needs to be used somewhere else. So we know that GTN is administered under the tongue because it's a quick way to be administered and absorbed and then acting systemically very quickly. Florence said, will it trigger to vomit or diarrhea? It's a good question. Do you mean in terms of toxins, Florin? Is that what you meant? Or do you mean the liver? Does the liver have capacity in itself to do that? Oh, it's a good one. I don't know if the liver does in and of itself. I think that's more the brain, the chemo trigger zone in the brainstem. I know that the brainstem has multiple inputs to it, like the gut will feed back to it. So if you have certain certain circumstances within the gut wall that it's like inflammation or certain chemical changes, it will feed back neurologically back up to the trigger zone and tell you to just vomit or get diarrhea. Diarrhea is probably more to do with you just lack absorption of anything and it just moves through quickly and you get diarrhea that way. Whether the liver has capacity on itself to induce those two things, I'm not sure. It wouldn't surprise me if it does. Take something in the liver is not good. I mean, if you had hepatitis or you had liver failure, I reckon you would get you'd get nausea and vomiting and diarrhea probably. But whether that's because the liver can kind of induce that, I'm not sure. That's a good question. Have you got anything to add there, Ewan?
No.
No. Okay. So I think that will probably do for first pass metabolism. Are there any questions around this kind of concept? It's very important. It's a bugbear for pharmacologists, well, not so much pharmacologists per se, but the ones that try to come up with drug development, because you may have quite an effective drug, at least within cells, but if you can't get it into the body orally, then it's not going to be very useful. So you need to come up with ways that either counter first pass metabolism, or you look at other ways to get the drug into the body. But orally is a very convenient way of giving medication. You don't want to bring a patient in and have to give through parental means all the time, because that would be quite invasive. Okay, let's have a quick question and see how you go with this one. So this question's underpinning absorption. There's a lot here. We want you to kind of work through it and think about it, because it's kind of underpinning concepts. Okay, so let's have a go through it. Now, these particular questions, and there'll be a few later on as well, we've kind of infused them with multiple parts to try to encourage discussion more, so that we would have a question like this in the final exam. In the exam, we won't kind of be as verbose with our answers that can be a little bit subjective. We'll ensure that the answers are very clear cut. Okay. All right. So the first part, children have a slower peristalsis compared to adults. Well, it's probably quicker, not slower. Aging adults or elderly will have a slower. So that first part is incorrect in terms of children. So that's therefore this one is incorrect. But if you were to have a slower transit time through the GIT, that in theory would increase drug absorption, because you're given a greater access time to absorb the medication. Okay. The only time when children, infants would have a slower, at least gastric emptying, would if they're having a lot of milk and they're big feeds with the medication, then it would take longer for the stomach to empty. B, that is true. So they do have a decreased amount of bile, and as you know, we do need bile to help with fat metabolism. So that one actually is true. In terms of topical medications, the infant has the thin skin, at least in the thin skin in respect to absorbing medication. So that's the age group that you have to be most mindful of if you were to give a topical medication, that they are likely to absorb it more efficiently. And remember, this is proportional to their size, etc. That the infant would be more of a concern. So I think, say, steroid creams would be more of a concern for the younger age group. And then D, babies have a decrease, not an increased. Okay, so that therefore that's not going to be correct. Moving to distribution, I won't spend too much time on this because I need to pass across to Ewan. But the main thing I just want you to know with distribution is the way, now you've got the drug into the blood, how does it move through the body? Okay, so we've got the drug here. So it doesn't really matter how it got there. It could be straight into the blood through IV, or we've taken it orally, but you've now got the drug in our blood. Okay, how does it distribute through the body? This is the volume of distribution. Will be determined by a number of things, and it's similar to what we saw in absorption. Is the permeability of the barriers, the pH, and the binding capacity. When we say the binding capacity, what are the proteins that we find in the blood that could bind to, or medications can bind to? Do we know what they're called? Anyone? So within our blood itself, we have particular proteins, and they could have an influence on the way that drugs could potentially bind to them. Close, Nikki. Not hemoglobin, but that is definitely a protein. Yes, that's right, Anna. So these are called plasma proteins. So plasma proteins will play a very important role for the way that drugs potentially will bind, and albumin being the strongest one. So albumin can be one particular protein that drugs can bind. And if a drug is bound to albumin, it therefore can't work anywhere else in the body. So usually speaking, it's only the unbound drug, the unbound medication within the blood that can be effective. If it's bound to the protein within the blood, it can't move out into other tissues, so it would be ineffective. Okay, so drugs that have a higher binding capacity to albumin, generally it won't have a very wide volume of distribution. It will just stay in the blood. Now, if the drug you wanted to use was in the blood, then that could be quite useful, such as, say, anticoagulants. But if you wanted a drug to work off somewhere else in the body, then it's not going to be very effective. Also, blood flow is going to play an important role. Some organs have a really good blood flow, so you're going to get a whole lot of drug to that area, but there's other areas of the body that has a very bad blood flow, so therefore it may not get enough drug to be effective. The last thing I'll just mention here is determining the fat contribution of the person. So when we look through the age spectrum, which category, so the younger person, the adult, or the older person has a greater proportion of fat? So Loretta's gone younger. Does anyone agree or disagree with Loretta? And Lexi's gone older. Anyone else? Sarah's got older. What? One more. What? That's what we're trying to figure out, Florence. So we're just doing averages here. So when we look at a typical quote unquote category, so adult, older adult, younger, do you think an older adult has more fat proportionally than an adult or a younger, say, infant or child? So basically, the older you get, the more fat, which means you have less lean tissue. Okay, so why we're telling you this? Well, essentially, fat-soluble medications will distribute wider in the older adult compared to water-soluble, and the opposite happens in infants. Okay. The last thing is just to be mindful of the different barriers that the drug has to overcome. So you may have some drugs that are very effective, but if you can't get it into, let's say, the brain, then it's not going to be of use. An example would be dopamine. If you wanted to give dopamine for Parkinson's disease, it doesn't cross the blood-brain barrier. So giving dopamine into the blood or orally would be ineffective. So you need to come up with another means of trying to get dopamine into the brain to overcome this blood-brain barrier. Okay. All right. So I'll pass you across to you now for the last two.
Right, let's try to smash this in 13 minutes, guys. So the next phase of pharmacokinetics is metabolism, and metabolism. So the term metabolism basically means chemical reactions in the body. And so if we were to think about metabolism within the aspect of pharmacokinetics, they basically refer to the reactions that inactivate the drug or target for excretion. So basically, chemical reactions that occur that will remove the drug from the bloodstream, basically. Okay. Next slide, please. So Matt had already discussed the first pass effect. This is just another diagram to show you how first pass effect occurs. So obviously when you ingest a medication orally, it's going to go through the GIT, through the small intestine, and enters the capillaries and then enters the liver. Now, does anyone remember from your pharmacology course what the definition of bioavailability is? What do we mean by bioavailability of a medication? Does anyone remember the definition of it? How long to take effect? Okay, maybe not how long, but it's actually referring to the percentage of a drug. Yeah, very good. Yeah, so how much? What's the percentage of a drug that actually enters the bloodstream or enters the systemic circulation? Very good. So obviously, when you are ingesting medication orally, the bioavailability is greatly reduced because it gets metabolized in the liver. And which is why, if you could please move on to the next slide, Matt. Because of the first pass metabolism, we've got all these other means of other alternative routes of getting medications into the body, and Matt had already discussed some of these. Okay, and obviously with GTN, the example that Matt had come up with, it's got a very heavy first pass, meaning that most of the drugs will get metabolized in the liver. So basically most of them will be removed in the liver, therefore very minimal amount will enter the circulation, which is why it's administered sublingually under the tongue to increase and enhance absorption. Okay, moving on to the next slide. I'll give you a better example of it. So if you look at the diagram, you've got the oral drugs, and as it enters the small intestine, some of them will actually get removed in the form of feces, okay? And the rest will enter the hepatic portal vein into the liver, and in the liver, some of them will get detoxified and some of them will get metabolized, and only a very, very small amount will eventually enter the systemic circulation. And if we move on to the next slide, it gives you an example. Let's have a look. So, don't worry about what's written on the left-hand side. You don't need to know the equations. This is just there for your understanding, for your reference. But if you look at the diagram, let's take an example of a medication with a dose of 300 milligrams. So basically, of the 300 milligrams, 30% of them will just get removed in the form of feces. That means that you're left with only 70% of the 300 milligrams that will enter the portal circulation, that will enter the liver itself. Now, of those 70%, okay, only 40% of the 70% will actually enter the systemic circulation eventually. 60% of them, okay, will get metabolized in the liver. So if we were to take an example of a 300 milligram dose, only 70% of it enters the liver. And if you do the math, it comes down to 210 milligrams. Okay, so only 210 milligrams enter the liver. And of the 210 milligrams, only 40% will enter the blood, which comes down to 84 milligrams. It's quite interesting if you think about it, because when you take a medication of 300 milligrams, eventually only 84 milligrams of it will enter the blood. So this really makes you think about the dosage of medications. Whenever doctors, obviously, nurses don't have prescribing power. However, when doctors prescribe medications, they always have to be mindful of this first pass effect and the bioavailability. So whatever is ingested orally, only 40%, okay, of what enters the liver will get to the blood. Quite interesting, isn't it? Let's move on to the next question. Yep, so let's quickly do this. In reference to how age affects drug metabolism, which statement below is correct? And I can already tell you that there can be more than one answer that is correct. Okay, we've got A and B. B. Yep. Good. All right, good. Yep, so A, children have larger livers proportionally than adults. Therefore, their ability to clear drugs from their system is enhanced. Correct. So children basically have, obviously, the actual size of the liver may be smaller than adults, however, proportionally. So if you think about the relative size compared to their entire body, obviously the liver is larger proportionally. Therefore, with a larger liver, their ability to clear drugs, so their metabolic ability will be greatly enhanced. B, elderlies have a reduced ability to metabolize drugs, which is true, and therefore these drugs' half-lives will be prolonged, because obviously when there's reduced metabolism, the drugs will actually remain in the system a bit longer. Okay, therefore the drugs' half-lives will be prolonged. Very good. Let's move on to the next slide, and let's try to smash this last phase in 5 minutes. So excretion. Obviously on the slide, there's the kidney, which basically is the main sort of means of excretion, because obviously kidneys will filter the blood. But can you think of any other means of excretion? How else would we excrete the medication? Like I kind of mentioned one other means when we talked about first pass metabolism. Okay, yeah, Florian says sweat, yeah, poop, sweat, absolutely, yeah. Feces, yeah. Anything else you could think of? Right, so Yep. Obviously through urine, through the kidneys, because remember what the main function of the kidneys is to filter, and therefore you would there'll be increased renal blood flow entering the glomerulus, and the blood will be filtered through the nephrons, and therefore most of the medications will be excreted via urine. Okay. Moving on to the next slide. Obviously, this is another form which you guys have already mentioned. It can be excreted through bile via the enterohepatic recirculation, and the rest of the drug will exit the body in the form of feces, as we have seen previously. Let's just move on. So you guys have mentioned the sweat, but it can also be excreted through the saliva as well. All right. And then through exhalation. So whenever we exhale, there's, although we don't see through the naked eye, there's part of the vapor, or not vapor, what's the word for it? There's some medications in the form of gas that will be excreted. Okay. Lastly, let's quickly do this last question.
That was supposed to be ethanol.
Yeah. So in reference to how age affects drug excretion, which statement below is correct? So again, there can be more than one answer to this question. Okay, so we've got A and C. All right, great job, guys. Yep, A and C, you guys are correct. So A, reduction in renal function in the elderly subjects, particularly a slower glomerular filtration rate slows the clearance of many drugs. Absolutely. It's said that from the age of 40, there's actually a certain percentage of renal blood flow that is reduced once you're past the age of 40. I think it was something like 1%. If I can't remember the exact percentage, but it's roughly 1 to 2% each year past the age of 40 that the glomerular filtration rate decreases. Okay, so with less renal blood flow, obviously less filtration happening, therefore there'll be drugs remaining in the body for a longer period. B, why is it incorrect? Neonates actually have decreased renal blood flow. Okay, therefore this cannot be the correct answer. And C, the daily dose of drugs that rely heavily on renal elimination should be lower in the elderlies compared to the younger adults. Again, this is sort of related to the answer A, because with the elderlies, they will have reduced glomerular filtration rate. Okay. That's it for me, and I think I've been great with time. It's 10 o'clock sharp now. Any questions, guys? Hopefully the session was helpful. Now you have a better understanding of the pharmacokinetics. You know what absorption, distribution, metabolism, and excretion is all about. Yes, it is recorded, Sonia. Anything you'd like to add before we end, Matt? Are you still there?
Oops, I was on mute. No, you did a wonderful job. If students got any final questions, even if there are assignment related questions in the 11th hour, we can take them. I will just turn off the recording now, and students are welcome to remain behind and ask questions.